So we move to the next speaker. And the next speaker is Irina Critescu from the Retinal Clinic in Bucharest, who will talk to us on microvascular features on AO imaging in diabetes. Thank you, Irina.
Good afternoon. My name is Irina. I'm an ophthalmologist trained in Romania, and this current research has been conducted at Retinal Clinic in Bucharest. Could I have next slide and next slide and slide after that? Okay, this one. So initially we studied, so I'm going to present the results of 3 studies. The first one is dealing with the vessel parameters in type 1 and type 2 diabetic patients without retinopathy. The second one, we wanted to see whether there are any differences in different stages of diabetic retinopathy with regards to retinal arterial parameters. And thirdly, we studied the effect of resveratrol on microcirculation in diabetic retinopathy. Next slide, please. So firstly, we have included 55 subjects, controls and diabetic subjects without diabetic retinopathy, type 1 and type 2. And the scans of the superior and inferior retinal arterioles, superior temporal and inferior temporal retinal arterioles have been analyzed using the rtx1 software. Next slide. The post hoc analysis between the groups included in the study showed significant differences of the wall-to-lumen ratio values between the control and type 1 and type 2 diabetic groups. Interestingly, between the 2 diabetic groups, no significant differences have been noted, despite a significant difference of diabetes duration between the 2. Next slide. Thank you. In the second study, approximately 75 subjects have been included, and we had controls, diabetic patients without diabetic retinopathy, with non-proliferative diabetic retinopathy, and with proliferative diabetic retinopathy. Significant differences have been observed for wall-to-lumen ratio values only between the control and the group with no diabetic retinopathy changes, and between the control and the proliferative diabetic retinopathy group. Next slide. It is worth mentioning that a consistent number of subjects from a non-proliferative diabetic retinopathy group had received Avastin injection previously for diabetic macular edema. And even if the injection had been given more than 6 months prior to the study, it could have generated a vasoconstriction effect on the vessel and determined the narrowing of retinal vessels. Next slide. Thank you. The third study focused on the effect of resveratrol on retinal arterioles parameters. The paired sample analysis between 2 paired observation in the study group, including 15 patients, showed improved values of the mean wall thickness, wall-to-lumen ratio, and cross-sectional area of the vascular wall after 3 months of daily treatment with resveratrol. Resveratrol seemed to reverse the retinal microvascular changes in diabetic retinopathy. Next slide. Next one. These 3 studies had small sample sizes, not extensive enough to draw a definite conclusion. Therefore, further investigations with larger sample sizes and larger follow-ups are needed to confirm the results. And in conclusion, that adaptive optics provides useful information about the retinal microvasculature from early onset of diabetic disease. It will play a very important role in the future. It's important for routine follow-up, can provide important information from the early onset of diabetes, and also it can help to refine treatment options. Thank you.
Thank you very much, Irina. So we go back to Nathaniel.
Hello. This is work I did with Michelle Pack at the Kensmount Hospital and in collaboration with Ethan Rossi at the University of Pittsburgh. And we started with the knowledge that up until present, OCT and color fundus have been the gold standard methods for studying and measuring drusen, but visualization of the smallest drusen proves difficult in these modalities. In the RTX image, which from now on we'll call FIO, drusen can be resolved, but with relatively low contrast. So we developed a new method to study gaze variations in AO. We started with an observation that drusen appear brighter in the periphery than they do in the center. And you can see that schematically represented over here on the right. Next, we inquired that if we have a patient come to the rtx1 and we take an image at the fovea, we move around in 2-degree steps all the way around to superior, to temporal, to inferior, then can we capture gaze variations? And we notice that these are the same 9 images I just described, and we have one druse that we've imaged 4 different images, but it otherwise the exact same. If we take a closer look at it on the right, we have validation from the OCT that is in fact a druse, but we noticed visually that these do not look the same at all. As before, on the periphery, the border seems much sharper than it does in the center, and we see that systematically in all directions. From this, we wanted to develop a protocol around this phenomenon. We registered these 9 images, each one has 50% overlap. We stitched them together and asked to use this phenomenon to enhance drusen visualization. In looking at the sum, we can appreciate the different number of images that contribute to each section. So in the center, we have 4 images, and in the corner, we have 1. So most of the information we'll get will be from the center. Next, we wanted to look at some statistical variations of this. We looked at the variance where we can see a significant increase in contrast, but just to zoom in, standard deviation ultimately gave us the most information and is now what we call the gaze-dependent image. And if we put this image back to back with the raw RTX1 image, we can see that the contrast of each structure is significantly better in the GDI, aka standard deviation image. Our next step was to apply this protocol to about 190 eyes, and most of them had intermediate AMD, and globally, we were very successful. Essentially, any patient that comes that can take a successful RTX1 image is eligible for this imaging protocol. Next, we'll do a multimodal comparison. Starting with the color fundus, in the bottom with these white arrows, we can see 3 small drusen here in yellow, and we can see them in the exact same spot in the gaze-dependent imaging, which validates that what we're seeing gaze-dependent is in fact a drusen. But interestingly, above with these yellow arrows, we have 3 small drusen that are actually below the detection limit in color fundus. So our next question was, okay, if we're detecting smaller drusen than in the gold standard methods, let's quantify that. So we had several graders take sets of images where they had color fundus, RTX1, and gaze dependent, and we had them count the number of drusen they saw, and every time, the most number of drusen was counted in the gaze dependent image, and then we had them also measure the drusen radius of several drusen in each image. So we saw that for medium or large drusen, all the radii are about the same no matter the modality. But as we get smaller and smaller, gaze-dependent imaging can detect smaller and smaller drusen than certainly color fundus, but especially both modalities. We can appreciate this visually down here at the bottom, where under about 30 microns, both the other modalities fall down, but gaze-dependent imaging gets stronger and stronger. We can see more for a lot smaller radii. So yes, we do have consistent smaller drusen detection in gaze-dependent imaging compared to the other modalities. So we've used this protocol in a bunch of different ways now on a few different imaging cohorts, but I just wanted to show you guys one way that we can use this effectively. So we see here a longitudinal study of drusen evolution over a 3-year period. Up here, we see one large druse getting larger and larger over time. We're able to measure those differences. Here we have 2 druses that start independently, kind of next to each other, and they form into one towards the end. And down here at the bottom, we have three small structures that form into one proper drusen at the end. And to conclude, we found that by increasing drusen visibility via contrast changes in rtx1, segmentation and quantification of drusen is now possible. We also did a comparison with AOSLO that essentially just showed us that scanning distortions are so much that it creates artifact, aka rtx1 and flood imaging is the best instrument for this kind of visualization. Our next steps would include applying this to other kinds of diseases, and Imagine was kind enough to make that process a little bit easier by adding automatic gaze-dependent imaging output on the rtx1. Thanks, guys. I want to acknowledge my team and everyone that was able to make this project happen, notably Michelle Pack, Kate Grieve, and Ethan Rossi. Thank you guys so much for listening.
Thank you very much, Nathaniel, and the four speakers. We are right on time, so we have time for some questions. Shoba, the four of you have shown us great presentations. Let me ask you, we've been relying on infrared reflectance images to diagnose cuticular drusen for a long time. And it is a challenge, no matter what technology we use. Do you think AO is the future?
Well, unless made easy to use, it is going to be tricky, but it will help us build our scientific knowledge on the pathogenesis of drusen, different types of drusen, the composition of drusen, and the morphology. I think it will create a lot of new knowledge that we weren't aware of previously, but to use it in routine practice, I think it will be later on. I wouldn't give it up, but I think it will be later on.
Yeah. We've got one more presentation, I think, because we changed the order. Marie-Hélène Herrera. We are looking forward to your presentation from the University of Pittsburgh School of Medicine, AO and multimodal imaging for inflammatory vitreoretinal interface abnormalities. Thank you very much, Marie-Hélène.
Thank you very much for the kind invitation. So I'm a visiting associate professor in ophthalmology in Pittsburgh, and I'm going to present you. Trying to move my slides. Sorry. I'm going to present you a collaborative work between Pittsburgh and Dr. Ethan Rossi Labs and 1520 Hospital, Professor Pack. And that's the opportunity to thank Professor Gocho, who 10 years ago taught me how to use rtx1 for the first time. Thank you. So the purpose of the study is to investigate the changes of the vitreoretinal interface in eyes with uveitis imaged by adaptive optics, and our team already work on uveitis and adaptive optics, and we showed how retinal vasculitis and inflamed retinal vessel can look like with this opaque sheathing around this vein inflamed. In that current study, we imaged 4 eyes of 4 patients with uveitis, inflammatory eye disease, and those patients were either affected by epiretinal membrane. Shown on OCT, we selected patients from group 1A ERM. You see on the left side of the slide, group 1A ERM look like on OCT. And other patients had a thick ILM, internal limited membrane, on multicolor imaging. ERM is epiretinal membrane. So the microstructure of vitreoretinal interface seen on adaptive optics were correlated to the cross-sectional OCT optical coherence picture. So the result, on adaptive optic images, we show multiple abnormality of the retinal interface. So in that patient with paraneoplastic syndrome, which is a masquerader syndrome, the melanoma is responsible of paraneoplastic syndrome, and we see its mimic retinal vasculitis. We saw deep linear striae associated with epiretinal membrane. So the deep linear striae are shown with the yellow arrows, and they were shown by the first presenter on the today. So it looked like dark striae, and it corresponds to the folds of the retina. And we saw hyperreflective microstructure associated with this epiretinal membrane and ILM as well. And they are shown into the yellow circles. They look hyperreflective. On the right side, bottom right, you see the cone mosaic, and there is an alteration of this cone mosaic associated with the epiretinal membrane. This other patient had a birdshot choroidinopathy, which is a white dot syndrome, a posterior uveitis. And we saw also the hyperreflective microstructure associated with the epiretinal membrane that you see on the OCT on the top right. And the hyperreflective microstructure that correspond to the epiretinal membrane are shown into the yellow circles. The photoreceptor, the cone mosaic, is completely lost in that patient, as you can see into the yellow square. This last patient had a pars planitis, which is an inflammation of the vitreous and of the pars plana in the periphery of the retina with retinal vasculitis. We saw a thick internal limiting membrane on the multi imaging, so it was infrared here, and we see the thick ILM. You see it as well on OCT in two locations shown by blue and orange areas, and on adaptive optics bottom left, you see the hyperreflective structure that correspond to the thick ILM, and they are shown into the yellow circles. In conclusion, adaptive optic imaging can image the epiretinal membrane and the internal limiting membrane feature in eye with inflammation. Thank you.
Thank you very much, Maria Elena. Nicolas.
Thank you.
Yes, I see that now it's already time to conclude this meeting. So what we are going to do is that we are going to say thank you now, but we will keep the Zoom session open afterward as extra time for those who want to stay for the more questions and let's say informal discussion. So thank you very much, Daniela and Paulo, for chairing the meeting. It was really great to have you here. And thank you all speakers for the high quality presentation. So we've seen wonderful results and images today. And it's a great motivation for us to continue developing the technology. And finally, many thanks for everyone attending. We keep all of you posted about our next events on AO imaging. And now for those who want to stay, we will have a few more questions, and especially for the speakers of the last session, Paulo.
Perfect. So we've got some questions for those who are still with us. Marie-Hélène, beautiful presentation. What do you think? I'm a vitreoretinal surgeon, so your presentation has been very interesting to me. How do you think we can use AO routinely before and after either ILM peel or ERM peel? What would you want it to show us?
So thank you. I'm a vitreoretinal surgeon as well. So when I was doing the picture, I was thinking as well surgery, and that's why we look at the photoreceptors layer with adaptive optics to see if the epiretinal membrane or a thick ILM in uveitic patients might correspond to a loss of photoreceptors. And it does, but is it a loss or is it an alteration that we see on the picture? So I think it will be interesting to do the peeling in those patients and have a look secondary if we get a better view of the cone mosaic after peeling.
Have you had a chance to look at the inner retinal degeneration after ILM peel? You know, when we see this beaten bronze pattern on OCT maps?
I haven't done these works yet. The problem with a patient with uveitis is that on the top of it, they can have a loss of the cones because of inflammation, chronic inflammation. So, so that will be interesting to do it with patients with after epiretinal membrane peel without inflammation, and after epiretinal membrane peel when they had inflammation. So there are, I think, two different categories of patients.
Thank you.
Okay, thank you.
We've got a question for
Sorry, Paulo, can I add a question to?
Yes, of course.
Thank you. Do you think, Marie-Hélène, that a pre-surgical assessment in a case of macular hole or peritoneal membrane with adaptive optics could add further prognostic information to our patients?
I don't know if it will be a prognosis, but I think we see very sick ILM, internal limiting membrane, on adaptive optics, better than with other imaging system, and that will be a help for the surgeon when he does a peel, where to start the peel during surgery. We have OCT during surgery, but it doesn't show where the internal limiting membrane, so we see it better with adaptive optics imaging system. It can be a help for the surgeon during surgery, definitely.
It would be very interesting if you could correlate where you start the peel with the pre-anatomic findings and functional testing afterwards. Really great work. Irina, how can you correlate your results with what on AO with what we see on OCTA in diabetics?
It's interesting because the microaneurysms, I'm talking about diabetic patients with changes.
Early changes, early changes.
Yeah, so the microaneurysms, they can be very well spotted with adaptive optics. Also, macular edema is very nicely depicted with adaptive optics. So we can see the classical diabetic changes with this tool as well.
Thank you. Nathaniel, you've very nice presentation. You've certainly seem to be showing many more findings with your protocol. Have you had a chance to look at cuticular drusen? Is your technique protocol a better one for diagnosing or identifying, differentiating cuticular drusen?
So we haven't looked too much into different kinds of drusen, but notably we're best on the small side where drusen progression really begins, versus a cuticular drusen is more developed, and I don't know if it would be as advantageous for this method.
Can you measure thickness of Brooks membrane? Are we there already?
Kyogo, if you mind advising on this, as I'm not a doctor, I don't want to lie to you guys.
Do you think we are at the stage of being able to measure Brooks membrane? John Marshall, Professor Marshall, has done a lot of work on reduced transport across Brooks membrane. Can we measure thickness?
Actually, I was now trying to see with the AMD case, because in the atrophy area, it was some continuous line. It remained just above the choriocapillaris layer, it looks like. And then some part, it's already the still residual part and atrophic area. So there is some difference. So maybe I think it is a Brooks membrane, but I haven't tried in the many cases. So I think it's going to be the future project.
That's going to be very cool, very interesting. We're really looking forward to those results. Can I ask you, Kyoko?
Yes.
What are the hyperreflective dots that people have shown in areas of GA? What is that?
I think it is a macrophage or some type of the inflammations where it is, because it looks like it's going to the vessels, the close to, it starts from the RPE and it's going to the inside of the retina. So there are several layers it exists. So I think it is some kind of the macrophage or some information cells that we are looking for.
One of the speakers, if I remember correctly, showed the hyperreflective dots in areas of GA. Is that correct?
What I saw was in the border area.
The border of the area of GA, yes, in the transition. Because we've seen them for years, for many years, with OCT, high resolution OCT in association with macular edema, for example, in vein occlusion. And we still see them in neovascular AMD. And we tend to believe that these are signs of activity, of neovascular activity. That's why I was asking, what do you, and we thought these were an inflammatory marker in, for example, in vein occlusion. So that's why the question, what do you think they are in GA? Because then we could say there's some inflammatory activity there.
I think so.
And that's why we are treating GA, with anti-complement therapy. We are blocking C3, C5, as you know, with Apellis and Iveric Bio.
Yes, I agree with there is information in the GA cases. I always thought that there is some information, and because we already published several pigment cramp and inflammation, something is moving around. So we thought it's some the feature of the information in the RPE or retina subplace. So, and several literature for the using the conventional OCT also proved there was some movement in the retina. So I really agree with you.
Marine, we cannot wait to have your multi-stage multimodal system. Daniela, do you want to make any comment?
Sorry, do you think, Kyoko, that these hyperreflective dots could be an agglomerates of puffy cones? Because we see in a lot of diseases these hyperreflective alterations, also in inflammatory disease, as in a case of or in other diseases.
Because I think it's another thing. What I see, the structure, it looks different. The photoreceptor itself, or maybe the RPE or something is different. But because not only AMD like GA case, this time I show only the AMD case, but actually in the inherited retinal degeneration cases, also I saw some hyperreflective fatigue in the AOCT. And also some X-rayed case, so like hypertension and also diabetic retinopathy case. So there are some reflex in the hyperreflective, but maybe the type of the cells, it's not the same, maybe. So I'm not sure about, because we have to go to the more history and the other things too to compare, to conclude. But there are, when there is some information, I think we see something more detailed with AOCT. It is what so far I can say that. Yes.
Thank you.
Nicolas, we go back to you.
Yes, still about these hyperreflective spots that you see on OCT, and it's a question maybe for both Kyoko and Marie-Hélène. So do you agree that we see these structures hyperreflective in OCT or AOCT, but in rtx1 images, they are dark, they are hyporeflective
zone?
Would you agree with that?
But actually, when there is a melanin included, so then there is a different hyperreflective. So then I think it's because in the infrared and the AOCL image, I think reflective is not the same. So OCT and then the rtx1 is not, I think it's always not the same. This is what I understood.
I agree with you. Definitely.
Okay, thank you.
Thank you. There is a last question from audience. Can adaptive optics make any diagnosis as a standalone imaging modality? I think that this is a hot question for all the speakers. I think that now multimodal imaging is very important to reach a correct diagnosis, but adaptive optics is a useful tool when we have some specific alterations to detect. But multimodal imaging is obviously the most important approach to our patient.
If I can say something, I've seen images of active retinal vasculitis on adaptive optics that were missed on fluorescein angiography. The first slide I show, we see an opaque sheath around the vessels when there is an inflammation. And sometimes it's very difficult to detect retinal vasculitis on fluorescein angiography because is there more or less leakage from the retinal vessel? It's difficult to tell. It's a very subjective analysis, fluorescein angiography for retinal vasculitis. And if we are lucky enough just to detect the focal inflammation on the vessel on adaptive optics, we need to screen all the vessels. If we see it, we are sure that there is a retinal vasculitis active.
Yes, of course, adaptive optics could offer to our imaging some preclinical biomarkers for retinal vessel assessment, maybe in some systemic diseases. Thanks to all the speakers for their presentation, excellent presentation. It has been an honor to moderate this session and to have this suggestion from you. Thank you.
Thank you very much from myself as well, Marine, Nicolas, for this invitation. Great presentations. Just when I was thinking that I started to know something about EO, after this session, I know how much more I have to learn, which makes it more interesting. Thank you very much. Extremely exciting.
Well,
thank you.
Thank you all
Marina,
again.
thank you, Nicolas. Thank you.
Thank you for the extra time as well.
Yes, thank you everyone for this great event.